Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Good morning or good afternoon for those of you joining us from the East Coast. Thank you for joining us today for this live webinar to help you prepare for the upcoming changes associated with the implementation of the patient-driven groupings model, or as we all know it, PDGM. Today, we will explore the positive impact of therapy usage under PDGM, the vital importance of a thorough therapy evaluation and functional assessment in the development of the plan of care, and how to empower our clinicians to maximize every patient interaction. My name is Laura Barnett. I'm the Director of Communications for Axxess. Before we get started, I'd like to tell you a little bit about Axxess. We're a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Today, you'll hear from two industry experts. First, I'd like to introduce and welcome Dawn Greaves. Dawn has 34 years of experience as a physical therapist and more than 15 years of experience in home health. Currently, she serves as the Vice President of Home Services for Aegis Therapies. Also joining us today is Wendy Conlon. Wendy is the Vice President of Client Services for Axxess. Wendy has more than 20 years of experience as a physical therapist in home health and has led the development of many clinical and program management models impacting the post-acute world. Before we get started, I'd like to share a couple of housekeeping items. Everyone's phones are muted. However, you may submit questions throughout the webinar. And if time permits, our presenters will answer as many questions as possible at the end of the webinar. If we don't have time to answer the question today, we will follow up with you via email after the webinar. And following today's session, we'll provide everyone with a link to the slides, and we'll also post a video recording of the webinar on our website at axxess.com. Ladies, take it away.
Thank you, Laura. Good afternoon and good morning to all involved. Hope it's a great Tuesday for you. This is Wendy. I'll start our presentation. I want to introduce our concept at Axxess. We believe the future of healthcare is in the home. We truly work to empower and improve the delivery of the quality healthcare services at home throughout our industry, through thought leadership and innovative technology solutions. And this morning, as we go through our presentation, we're really going to focus on why empowering healthcare delivery in the home is so important, with that focus on therapy. Our learning objectives today, as an industry, we have varying degrees of thought surrounding the impact of PDGM on our industry, and truly how therapy plays a role in that thought process. So let's focus in on that. Let's take a deep dive today. Dawn and I want to walk you through PDGM and therapy, value-based therapy, and what that really means, our PDGM therapy expertise, determining our functional status and the importance of that, and then truthfully looking at a successful PDGM transition. We know that now it is July and upcoming January 1st, 2020, it'll be here before we know it. So what does that look like for a successful PDGM transition now? Our focus today, as always, we must really consider that utilization must be tied to functional outcome. That is incredibly important in our post-acute landscape. So what do we know? This is truly the value of home care and speaks to our post-acute strategy. The majority of our healthcare dollars are utilized in the last 18 months of life. It's pretty significant. And on top of that, a quarter of traditional Medicare spending is for services in the last year of life. When we consider the daily cost of a hospital stay versus the cost of care in the home, keeping folks in the home to heal becomes paramount. And above all that, people want to be home. So we know that the post-acute landscape is going to continue to grow. And how do we navigate that through PDGM and particularly through therapy?
Right, and as Wendy just stated, we know that our patients want to be at home and they want to age safely in place at home, right? So as we look at therapy's role in supporting that goal, it's important to understand the link between function, risk, and outcomes. And we know that research has shown that lower levels of functional ability increases the patient's risk for rehospitalization. In fact, a study in 2012, as noted on the slide here, suggested that with lower levels of ambulatory activity at hospital discharge, older adults are 6 times more likely to be rehospitalized. An additional study noted here was that adults that go home with a new unmet activity of daily living need or 3 to 5 ADL disabilities are also much more likely to be readmitted. So it's not only important the functional level that they have, but whether or not that's a new decline in an activity of daily living for them. In the case of the last 2 studies that are noted here on the slide, lower functional ability was also linked to increased risk for death, so mortality, and institutional placement. And we know that the institutional placement adds cost to the overall system, but more importantly, is not where the patient wants to be. It's important that the use of standardized tests and measures, such as the short performance physical battery test, which is noted in one of these studies here, can help to quantify these risks for patients and individuals. So looking to the evidence for how we manage our patients. And importantly, research has also shown the connection between the delivery of therapy services and decreased risk for rehospitalization, such as in this study by Dr. Wang. The authors concluded that an average of only 1 to 2 home health physical therapy sessions a week can help lower the risk of rehospitalization by 82% in that targeted population. So pretty significant findings that function is really important to our risk for rehospitalization and institutionalization, as well as therapy's role in helping to prevent that risk for rehospitalization. So functional ability and therapy utilization and risk. So let's take a look at a couple of the key points specific to the patient-driven groupings model, or PDGM. We know that the Bipartisan Budget Act of 2018 mandated a couple of things specific to home care. One, that therapy visits or therapy volume must be removed as a determinant of reimbursement on or before January 1st of 2020. So that's been mandated by Congress. So we know this change is coming, and it must be budget neutral to CMS. It's a resource-based model of care. That resource utilization was determined based on 2017 data. So CMS looked at all the resources that were utilized to provide care as they put together this model based on that 2017 data. CMS's goal was to move from volume to value and ensure appropriate reimbursement for all types of patients eligible for home health benefits. So sort of a recalibration of that system overall, looking back at the resource utilization and developing this model to ensure that all types of patients would have adequate reimbursement under this model. As we noted earlier, the therapy thresholds have been eliminated, and a lot of the talk and focus has been specific to those therapy thresholds. There are many other things that are changing about this model. Since it's a resource-based model and it uses patient characteristics to align reimbursement, it aligns that reimbursement for that individual patient, and that should tie to the patient's needs. So consideration of how we assess the patient, how we address the questions in the OASIS, how we do our functional assessments can be really important to ensure that we have the resources available, aka reimbursement to the agency, to provide the care to meet all of the needs for that patient.
So what happens with our patients under PDGM? And what we have to remember is the physiology of the geriatric patient does not change January 1st, 2020. On January 1st, 2020, our geriatric patients aren't going to jump out of bed and have no balance deficits and be able to breathe easy and start running circles around us, right? Our patients will still look as they do today. What will change is truly how we focus on our management of the patients to some extent, right? We know that while our medical procedures have become less invasive through technology, leading us to less tissue damage, the healing process for the human body and the human systems remain the same. So truly, we want to focus on what is happening with our patients and making sure under PDGM, as always, that we are providing the absolute best picture of what our patients will look like. And we'll be looking at our patients thinking about our admission source. Are our patients coming from an institutional setting, such as a hospital, where they may be more acutely ill, or are they coming from a community setting where they've had a change in status, however, not necessarily related to a hospital stay? From a clinical grouping perspective, what is the patient's diagnosis, and how do we center around that? How do we build out our plan of care surrounding that diagnosis? A patient's functional status, clearly a very important portion of our PDGM roadmap and picture. What is this patient able to complete in terms of their daily living tasks, and how safely are they able to do that? Also, how efficiently? What does their energy loss look like there? And then comorbidities. Comorbidities are going to play a very significant role under PDGM. We look at our diagnoses, our primary diagnosis as our fire, and that's our focus. That's why we're seeing this patient. And then our comorbidities really fall to that smoke around that fire. We know that smoke contributes to the fire, and we have to really delineate out how those comorbidities play a part, all of which must be very clearly documented as we move forward. Looking at the clinical groupings, this is an opportunity from CMS to take a look. This is what CMS has published as their projection for the clinical groupings under a 30-day window. And so what we're looking at here is most of our patients are going to fall into three pretty significant categories. We look at the musculoskeletal rehab and the neuro rehab, 18.4% and 10.4% respectively. Those speak to a lot of potential therapy need. Additionally, our cardiac and circulatory MMTA, which is 17.5%, looking at where therapy can make an absolute benefit for the rehab of those with cardiac care concerns. So as we look at our diagnosis and as we look at our current patient population, as organizations, let's think forward into how our patients are going to fall into these categories under PDGM and how that makes us think about our 30-day periods and managing those with best clinical practice. As an industry, what is the goal of home care? We need to stay focused closely on what our goal is. That doesn't change under PDGM. We want to improve our patient outcome. In doing so, we want to improve our patient's function. We want to make sure that we're keeping our patients safe in the home by reducing our fall and injury. Therapists are very, very keenly aware of function and fall risk and injury, and creating a plan of care, an appropriate plan of care around that to lead to improved outcome is paramount. Looking at medication management, what are the patient's medication behaviors? Does this patient currently avoid taking their medications because it doesn't make them feel well, or they feel that it's a reminder of their illness, versus a patient feeling that their medications lead them down that path of independence? Having therapists knowing and understanding, and this is part of our bandwidth, understanding the side effects of those medications and helping to support the overall plan of care for medication management and compliance. It's key to the success of our patient outcome. Our condition management, we really want to avoid thinking about therapists only for those clinical groupings that really speak therapy, right? But truly looking at what the functional need of the patient is in accordance with their primary diagnosis, and tying that therapy plan of care into condition management and managing the congestive heart failure, the COPD, the diabetes, all those pieces. Therapy plays a very key role. And then, of course, aging in place. Again, we do believe that the future of care and healthcare is in the home. Patients want to be home. Therapists play a very, very significant role in encouraging folks to be able to stay in their environment. The other goal and large goal that we've been charged with in the post-acute space, and very fairly so, is to reduce our hospital readmissions. Again, when we reflect on the cost of Medicare in the last year or so of life, we can see that a hospital admission certainly really drives that cost up, where we can be preventative in the home and keep folks comfortable and truly happy in their home environment. And that all leads us to that stellar patient satisfaction. Again, these are our value-based measures, right? Ensuring that the patient has a voice. And when we employ an interdisciplinary team into a patient's home, that stellar patient satisfaction comes tenfold. So why is therapy important? What is important for therapy? Truly, looking again at PDGM as a whole, we've talked a lot in the industry about that, the importance of that detailed referral when we think about institutional versus community and where these patients are coming from. As therapists, we love to dig into that 30-page referral from the hospital and really look at where that patient's been, what kind of care they've received, how they were moving around in the hospital. That is phenomenal. That detailed referral is really going to help us with our documentation future forward, which really justifies our need. Accurate coding, thinking now about our coding and what those questionable diagnoses are going to look like. We know that a lot of those diagnosis codes right now tend to fall under therapy, right? The muscle weakness, the gait abnormality, those codes will no longer be reimbursable under PDGM. And you know, that's okay. Those codes tend to fall under a symptom code. What is the true diagnosis of this patient? If we have a patient with congestive heart failure and we can see functionally that they're at a deficit, therapy can be absolutely imperative in assisting and supporting that patient's recovery, helping the patient learn how to take their weight every day by physically helping them get on the scale, seeing if they can read that scale, how can they record that reading. All of that becomes that condition management that therapists can really support. And we do that through knowing that accurate coding and building that plan of care around that. Looking at a thorough functional assessment. Well, boy, oh boy, as therapists, we are certainly down for this, aren't we? It's our show me. Show me how you get into the bathtub. Show me how you get into your bed. Show me how you reach in the cupboard to take your pills. Those are the pieces that therapists are looking for, and throughout that functional assessment, we're absolutely outlining a plan of care for the success and safety of that patient to complete those tasks. Thoughtful evidence-based care planning, this is truly where it is, and we need to really be thinking about this now in July of 2019 for forward future for 2020. What are our evidence-based practices? What's working for our current patient population? What's known in the industry? And how do we maximize implementation of these evidence-based care plannings with our teams? That's critical to our success. Motivating our teams to use objective data in creating their care plans versus coming from the heart. We know as clinicians, we tend to come from the heart, which is great, and that's great connection with the therapist or with the patient. In building out our plan of care, however, focusing in on that evidence-based care is critical. Utilizing our PTAs and our CODAs. Our PTAs and our CODAs are invaluable. Our PTAs and CODAs focus on treatment and patient-centered care in a very unique and absolutely remarkable way. As a therapist myself, I focus a lot on evaluation, right? I certainly can dive in and work very quickly and diligently on a functional treatment, but I'm really looking at that evaluation piece. Our PTAs and our CODAs can take that plan of care and that treatment model and turn it functionally into an absolute magic experience for a patient. And so we need to really invest in our PTAs and CODAs and help our therapists, our physical therapists, our occupational therapists, really drive in and buy into the importance of using our team, looking at our team as a whole for the betterment of the patient. We need to maximize every skilled encounter. Every moment with our patient counts tenfold. We need to learn to employ every resource that's available to us in the home and maximize those encounters so that that patient can really drive to great success with appropriate utilization. Looking at implementing our telehealth. Telehealth is a phenomenal resource in our industry. It allows us that touch point with the patient, can allow us that touch point daily. We're gathering data. We're engaging with that patient to ensure that they're compliant and that they're understanding what we're asking them to do. And telehealth can be a phenomenal resource. Finding a solid telehealth provider and partner for an organization is really going to elevate outcomes, absolutely employ appropriate utilization, and really lead to success under PDGM. There are many wonderful telehealth programs out there, and I encourage you to really take a look at how you're partnering with those groups. Looking at an ongoing interdisciplinary assessment and discussion, you know, CMS has always promoted from a communication standpoint that we have strong interdisciplinary communication, that we're working together as a team, because we know our clinicians in the field tend to be a bit autonomous, and coming together on an interdisciplinary communication is key. But now CMS is really taking that a step further when we look at our OASIS, completion of our functional assessment and our OASIS, and the collaboration amongst team members. Certainly there's an owner to the OASIS, and that person is certainly assessing, but we're really looking at how we're collaborating and looking at that patient as a whole, and how are we scoring that patient. Knowing how to accurately reflect what we're seeing from an interdisciplinary perspective and documenting that on the OASIS is key. It's key to setting the foundation for the plan of care. And then, as always, our focused, goal-oriented care, providing that efficiently. Staying true to the plan of care, the focused plan of care that we've settled on, from the detailed referral, from the coding, from the assessment. Staying true to that plan of care, staying focused on that plan of care with every moment of every visit, leading to those goals, is going to take that patient to the levels where we need them to be.
So that's a great overview of the things that you can begin to look at from the therapy perspective, right, to impact care under the new model. An important part of knowing where you're going or building a plan is kind of understanding where you're coming from, right? Where are you starting? And so it's going to be important to know your baseline and to really understand the impact variables to better understand what may impact your reimbursement as an agency under PDGM. So in the next few slides, we'll look at the role of questionable encounter codes, or what they're referring to now, I believe, as QECs, the functional scores, and then move into therapy's role. So looking at questionable encounters. So a questionable encounter is a code that will no longer crosswalk into a reimbursement category under PDGM. And there are over 70,000 ICD-10 diagnosis codes. Under PDGM, only about 43,000 of those codes in the PDGM grouper tool crosswalk to a clinical grouping, and only 3,067 of those codes actually fall into a comorbidity subgroup. So really important that you understand coding and how that impacts the which clinical group it falls into in the new world. So what's your agency's risk for questionable codes? I attended the NOC PDGM Summit in February, the one that was held in New Orleans, and this is one of the slides that they presented that really stood out to me. On the left, you'll see the agencies that in 2017 had the highest percentage of nursing visits. And so if you think about it as a relationship, that would be groups with the highest percentage of nursing visits, therefore the lowest percentage of therapy visits or lower therapy utilization. And on the right, you have the opposite, the lowest 25% of nursing, therefore the highest 75% of therapy. And you can see that there's a direct correlation. It goes with the number of questionable encounters going up, the further over to the right that you get, so that higher therapy utilization. So a questionable encounter code is a code like weakness. It's a symptom code, falls, generalized weakness, difficulty walking. Those are the types of codes that under PDGM don't crosswalk. And if you think about the primary codes that we sometimes utilize in a therapy-only case, those could tend to be questionable encounter codes. So it's going to be really important that you understand your risk as an agency for those questionable encounter codes if you're a higher therapy provider. Another factor that could contribute to the risk for overall questionable encounter codes, and again, this is from that same NOC summit. The first slide that I covered was from the LDS data file, and the second is a subset from the Ability Network, their national client database for 2017 episodes. And what this shows us is that for community admissions, your risk of questionable encounters with this particular subset that they looked at was significantly higher. So early community had 34% questionable encounter codes. So if you're looking at your impact for your agency and you're a high community admission, whether it's early community or later community, the evidence is showing us that you will have a higher risk for questionable codes. So just a couple of things to consider there. How functional impairment is scored under PDGM is changing, and it's changing fairly significantly. This characteristic can make a significant difference in your agency's reimbursement, and so it's going to be really important to understand this variable. We're not going to go into detail on this. We could spend an hour going through this table and then the table that came from the app technical report, diving into the functional scoring. But want to make a couple of key points here. Grooming's been added, and so while we've done a lot of focus and education around the functional codes, the upper body dressing, lower body dressing, bathing, toilet transferring, maybe need some additional education in your agency around that grooming code to make sure that we're capturing that accurately. The responses have all been grouped into response categories, and so not all responses from the OASIS will deliver points. But some of the weight or point differences between the answers are pretty significant. And so if you look at bathing, the difference between response category 2, which is answer 3 or 4 on the OASIS, it's being 13 points, and response category 1, which is response 2 on the OASIS, being 3 points, that's a significant difference. And so I think understanding the impact that these points have as they feed into the functional score is going to be really important. So just knowing also that risk for rehospitalization is an item that is now under the functional impairment summary table. You have to check 4 or more items, and those responses have to be responses 1 through 7 because the other responses don't count. But that risk for rehospitalization question is 11 points as it feeds into the functional impairment summary table. So why is this important? The next slide shows a few examples of the impact of the functional reimbursement. So let's look at an example. The top example is complex nursing clinical group. In both the first and second bullets under the complex nursing example, timing, admission source, comorbidity level are all the same, and of course the diagnosis of complex nursing. So the only variable that shifted in this example is the functional score. And low functional impairment versus medium functional impairment shows a case mix weight difference, so a reimbursement difference of 17%. And then you can see a couple of additional examples, MNTA endocrine, 19% difference, and a cardio example there with a 13% difference. So we talked earlier about this model being developed based on resource utilization, and this is one of the areas where CMS accounted for additional resource utilization based on the patient characteristics of functional impairment. So it's important that we get this scoring correct so that the agency gets credit for the complexity of the patient and therefore has the dollars needed to take care of the clinical need for that individual patient. The next slide shows a tool that we have available that will soon be posted out on our website. And this is just a PGM Casemix weight analysis by clinical group. I'm a very visual person, and so taking all of the complexities of the characteristics and putting it into one graphic where I could look across and see across the top is each of the clinical groups there in blue. Down the side, you'll see the source, timing, the functional level, and the comorbidity level. And it's just an easy reference to kind of take a look at, I wonder what the functional difference is between these two things. But tools such as this are just help you begin to get a better picture of the impact of each of these characteristics of the model. But that's just the start, because you're really going to need to be able to rely on your software and systems to help you better understand the impact by providing you with feedback on what today's patient would look like under PDGM. So if you don't already start seeing some of those things coming through your software vendors, you know, it's going to be important to start asking them when you're going to be able to see that, because you need practical, applicable knowledge now to start helping you understand the true impact of PDGM to your specific agency and how to prepare for that. So what about how therapy ties into outcomes? I think this is an area where we don't have great research to say this many visits leads to this outcome, right? That research does not exist currently. We know that there's good research that shows that functional improvement is more significant in patients with therapy involvement. But what does it look like specific to overall outcomes? So I'm going to direct you to the right-hand side of this therapy intensity delivered. So as we've talked about the model, the first quartile is on the left here, the lowest 25% of nursing, and therapy, sorry. So inversely, the highest percentage of nursing visits delivered, all the way across to the highest therapy delivery, therefore lowest nursing visits delivered. And this is out of the impact file. So we took the agencies from the impact file and we overlaid that with the home health compare data and the star rating. And so you can see the star rating reflected there. And then the got better at bathing is the blue, got better at breathing is orange, et cetera, as you look at the key there. So there's a trend in this data that as therapy utilization goes up, comparatively speaking, in the agency, the average patient care star rating goes up, as does improvement in these specific areas. This shows a relationship. It's important to note this is very high-level data. So it's taking the agencies from the impact file and comparing those agencies to how they perform on the outcome measures. What it doesn't do is draw a specific cause and effect, right? That this many visits leads to this outcome. But what it gives us is the beginning of an understanding of the relationship. And so how we respond to PDGM from the utilization perspective has the potential to impact outcomes. We just need to be aware of that, I think, as an industry and your agency specifically, because you work really hard for these star ratings, and you definitely want to be sure that whatever treatment strategies you're deploying are based in the evidence, are specific to the patient characteristics, and therefore will have a predictable outcome that you're looking to achieve. And next, Wendy's going to speak to delivering therapy quality under PDGM.
Thank you, Dawn. So let's pause and really breathe on this slide for a minute. This visual is pretty impactful as we look forward into PDGM, consider where we are now as an organization and what it's going to look like moving forward. Generally speaking, when we look at a visual like this, that center circle, We see here primary diagnosis, and generally in healthcare we see patient, right, at the center. And I want us to understand patient is right in the center with that primary diagnosis. Success under PDGM is really focusing in on that primary diagnosis and understanding what exactly is happening with this individual patient. So patient still remains at the center. And then looking from the top, we'll take a quick roll around this circle so that we can focus in on the slides upcoming. Looking at the assessments, objective tests and measures, those are key to justifying our need, to understanding where the patient is and realistically where we can take them functionally with our interventions, and driving that to success under PDGM, what that looks like. Interdisciplinary collaboration. We spoke about that a few slides back. We can see the evidence of that when we're looking at the quartiles and we're looking at the difference when we have therapy involved, really collaborating that care for the best possible outcome for that patient. Developing a very specific plan of care that keys into that primary diagnosis and to truly paint the picture of what's happening with the patient and how we're going to manage that patient to success functionally, and also keeping them out of the hospital, keeping that care in the home. Maintaining our functionally based treatment, thinking of what that patient needs, what their abilities need to be to safely move around their environment and live in their environment. And when I say live, I mean truly live, not exist, but live in their environment. What does that take functionally for us as a team? Condition management, we spoke on that a bit, making sure that we're looking at how therapy, what are we doing now for condition management with our therapy team, and what does that look like under PDGM? How are our therapists successfully managing the primary diagnosis, the cardiac care, the neuro care, thinking about those clinical groupings? How are our therapists now managing those, and how effectively will we utilize our therapy to manage those under PDGM? What does that mean? And then documentation. We have all known for many years as we entered our career, documentation is always the key to our success, and ensuring that we are justifying our need to be treating this patient, that we've set realistic expectations for this patient, that we've engaged all possible resources, and that we solidify what we're doing through our documentation is key to our success under PDGM. And we will see that as we develop those evidence-based care pathways that really are going to be the way to go. So in summary, what should we be paying close attention to for success under PDGM? And again, I would say this now, we need to be thinking about our coding. Dawn talked about it, I've talked about it, avoiding our questionable encounter codes, looking at our fire versus our smoke, our comorbidity, our smoke, right? And how does that play into development of a solid plan of care and patient representation under PDGM? Additionally, let's look at our 30-day periods. We know that come January 1st, 2020, that we are going to be considering payment periods of 30 days, broken down into 30 days. So developing those patient outcome-driven clinical pathways, optimizing our visit utilization for optimal patient outcome. What does that look like under a 30-day plan versus a 60-day plan? We know industry-wide, we've seen that our length of stay in home care has decreased over the years, and CMS is trending that as well. So that's where we have our 30 and 60-day periods spelled out. As Dawn mentioned, looking at your technology partner and ensuring that they have the tools to help understand what the 30 and 60-day payment periods are going to look like. Axxess has our PDGM modeling tool now that spells that out, and we can plug in for a patient that is not tied to a patient chart. It is truly a tool, a modeling tool to be used to look at what a specific diagnosis code is going to look like under a clinical grouping based on the functional impairment score, and also breaking that down by the two 30-day periods. What does the visit utilization look like, and what does the LUPA rate look like? Because we know under PDGM, we are going to anticipate a significant increase in LUPAs, which is going to be a challenge for our organizations in our industry and for our agencies to manage. Looking to our software to ensure that there are tools now that can help us know and analyze our organization now, so that we look future forward and this transition becomes relatively seamless to PDGM. We talk about also looking at the functional impairment group and tying that into our clinical grouping. Again, that goes to the condition management and the true utilization of our therapy resources. But develop those therapy patient outcome-driven pathways according to those groups, and that will lead us ultimately to that optimal utilization and considerable favorable patient outcome. So what are our considerations for therapy? What do we need to know now? We need to know and understand our current therapy utilization practices. How many of us are meeting with our therapists and really looking at those episodes where we've had significant patient outcome and what the therapy effect and model looked like in those. Now is the time to really take a look at that and engaging our therapists in doing that, so that they can really provide their key insight as to what's happening out in the patient's homes for that matter. Dawn spoke about the standard and validated testing, and those are keys to completion of a thorough therapy assessment. There is a list here that therapists are very familiar with. By no means is this an inclusive list, all-inclusive list, but look to your software to ensure that these standardized assessments are baked into your software, so that we're not using multiple resources to obtain this information. Make it part of the therapist's day-to-day so that they can use that. We know our Axxess therapy assessments and follow-up have these baked in, and that is considerable help to our clinicians, supporting and empowering our clinicians to provide that high level of care in the home. It's imperative that we establish that functional baseline through these standardized assessments, that we correlate that back to the primary diagnosis, and then again, we repeat these tests throughout so that we are validating what we're doing from a therapy perspective. That's your evidence-based planning that we're talking about. We've talked about the disease management and engaging our PTAs and our CODAs. I think I can't speak to that any more importantly. We want to implement a robust home exercise program and truly solicit the caregiver engagement, but also the environment engagement. We want to be incorporating this home exercise program into the daily activities to make it meaningful for the patient. Let's think about this. And again, engage our therapists in this, talk to our therapists about this, but having a patient stand at the sink and do leg lifts, 10 on each side, that's not where we want to be. We want to be engaging the patient in what's meaningful activity to that patient and how they get around in their home, and incorporating functional-based exercise that they can do while they're moving in meaningful activity in their home. It's going to increase their compliance. It truly validates the need and therapy, and it really leads to incredible outcomes when we do this. We've talked about the telehealth programs and engaging video monitoring and engagement for our patients. Think about where technology is today, back from where I started. And by the way, I loved Laura's intro. I stopped counting at 20. So, so that is a true statement, Dawn. I appreciate how far you take that. I stopped counting at 20 years ago, but when I started, everything was on paper, and I was still using payphones to stop and call patients when I was on my way to their home. Look at what we have now, where if we have a patient that's struggling with an exercise plan or struggling, getting on and off their scale, and we can have a video monitoring where we can engage with that patient rather quickly, also while monitoring their vital signs and their disease management across the way. Really and truly, technology is our friend here. So from a therapy expertise piece, we want to work smarter. We want better communication. We need to clarify the why and make sure we're articulating that through our thorough assessment, our purpose-driven care, knowing the OASIS. We're going to talk about this in a moment because I think we can do a phenomenal thorough functional assessment. But if we don't understand how we translate that into an OASIS, we're not going to see that functional outcome that we're looking for, and we're not really going to be able to engage our resources as we need to. Engaging the therapists that are doing well with these points, that are managing patients well with appropriate utilization and optimal outcomes in our agencies, looking at that now. Bring those therapists in to educate the other therapists, to educate the other nurses, and even our social work folks, folks that are engaging with that patient, this entire interdisciplinary team. The more we can collaborate together to teach each other what we're doing, the better the outcome and the better overall we'll utilize our skill. So looking at functional status, we want to observe that patient. I talked about that earlier today, the show me, right? As a therapist, we want to get in and have that patient pull their clothes out of the closet, and let's look at what's happening with their balance when it comes to that. How are they leaning? What are they using? Are they using a walker, or are they embarrassed to use their walker? They want to be independent, so they're using the wall and the sofa. Well, that's not safe. How do we analyze that safety for each of those MOOC questions on the OASIS, and then score them appropriately, looking at considering that safety component in those answers and considering all elements of what that question is asking. Have that patient show us. Certainly interviewing the patient and the caregiver, CMS is encouraging us to do that as well, to understand the patient's common movement patterns and their daily routine. Then taking this information from all those folks the clinicians that have been in the home, collaborating accordingly so that we can ensure that the clinician who owns that OASIS is has truly experienced a full assessment to be able to answer those questions correctly. Very, very key important component to that OASIS. Start now really walking through each of those functional questions for those therapists now. Take your weekly meeting times or your monthly meeting times to go through those functional OASIS scores now. That will help build the knowledge that the therapists really need and that the nurses really need going into PDGM. Create those strong interdisciplinary communication lines now. Your software system certainly can support that strong interdisciplinary communication and lead that to success. We want a unified plan of care addressing the specific need of the patient. And by looking at how we're scoring OASIS, looking at that thorough assessment and the communication, that plan will be identified. We need to align our clinicians for that interdisciplinary care. We want to optimize our resources. That's where we look at our telehealth. That's where we look at each other as clinicians and carrying out that unified plan of care with each other. We want to keep focused on value over volume. That is critical. Decision-making care focuses on evidence-based clinical pathways versus that clinician deciding on their own, and that's where we find that value over the volume. Again, know our numbers now, know where we are now, know what our therapy utilization looks like now, know what our patient outcome looks like now, and we want to avoid radical changes without that detailed analysis, because we know that functional piece, that functional impairment, weighs heavily future forward. We need to be utilizing it appropriately and empowering our clinicians to do so. So one thing to hold on to and remember, the skilled eye of a therapist to accurately define the patient's deficiency is truly the foundation of a successful functional outcome. Implementing that therapist and utilizing their skill appropriately is truly the greater effect of therapy under PDGM and leads us to the road to success. We've added some resources here for folks to take a look at. Aegis Therapies has a significant PDGM resource page that you can find here. As Dawn mentioned, the slides that were shared during this presentation will be posted in the near future, but currently the Aegis Therapy PDGM resource site is pretty significant. Our Axxess PDGM resource site is incredibly extensive, providing a lot of thought leadership and industry knowledge in our resource center there. We encourage you to take a look. And again, these slides will be posted there as well following this webinar. We want to inform you, and we're excited to announce that Axxess will be hosting one-day seminars in locations around the country Attendees to these seminars have the potential to earn 7 CEU credits. So more information about these events can be found on the URL below in the right bottom corner, but you can see that we are certainly crossing the map, as we say, with these seminars, and we're truly looking forward to that opportunity. We hope you join us at one of those seminars. Thank you for attending the seminar today. Laura, with our final thoughts.
Thank you, Dawn and Wendy, so much for sharing your wisdom and your insight to help us prepare for PDGM. As Wendy just mentioned, we'll have a link to the slides and post a video on axxess.com. The good news is we got a ton of insight, a ton of knowledge, a ton of preparation. The bad news is we're out of time, so we won't be able to answer the questions that came in. But if you did submit a question, do know that we will be in touch with you via email in the days to come to make sure that you get that response. We want to thank you so much for joining us today as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Have a fantastic day.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.